So I thought I'd do a follow-up video to my previous post about who's at risk for esophageal cancer and just talk a little bit more about how we actually treat Barrett's esophagus. Barrett's esophagus, which I talk about in that post, is the precursor to esophageal cancer. It's the result of longstanding acid reflux. And what happens is over time, just from acid coming back up into the esophagus, those cells start to change. And the first change we see is something called Barrett's esophagus. And over time, that can progress through a sequence next to low grade dysplasia and then to Barrett's esophagus with high grade dysplasia, and then eventually esophageal cancer. That's a process that takes many years. So, sort of like with colon cancer, the goal is always to try to identify those patients who have Barrett's esophagus so that we can intervene before it ever turns into esophageal cancer. So, who should be screened for Barrett's esophagus and for esophageal cancer? The main risk factor is longstanding acid reflux. If you've had a long history of it, it's worth talking to your doctor about getting screened for it. Other risk factors are age above the age of 50, obesity. Men are also at somewhat higher risk, and then anybody with a family history of esophageal cancer or Barrett's esophagus. So the way that we screen for it is with a very simple upper endoscopy. It's a very safe, quick procedure. It takes about 10, 15 minutes. It can be done at the same time as your colonoscopy. And if you do have Barrett's esophagus with dysplasia, then that's when we typically go in and do the treatment with what's called radiofrequency ablation, sometimes a different procedure called endoscopic mucosal resection, but it's the radiofrequency ablation or RFA that is the most common treatment. If you don't have dysplasia, then we typically just make sure your acid reflux is well controlled and monitor with an endoscopy every couple of years because without dysplasia, the risk of progressing to esophageal cancer is really, really low. So I'm going to share a video here showing you what the actual ablation procedure looks like. So this is a device called the Halo 360 balloon. It's been placed over a wire via endoscopy, and you actually can see the copper coils of the balloon there. This is in the proximal esophagus to start. You're going to see the next step here is the balloon being inflated so that those copper wires are actually in direct contact with the Barrett's mucosa. And the Barrett's part is that pink part. So the white mucosa is normal appearing esophagus. The Barrett's is the pink tissue there. So here the balloon is going to go up, um, and then that's how the ablation starts. There's the balloon being inflated, and now we're actually looking on the inside of the balloon, so you can get a really good view of those copper wires in contact with the Barrett's mucosa. The endoscopist here is putting his foot on the pedal so that the ablation is taking place, and then the balloon automatically deflates, and you can see how that pink mucosa is already starting to look white, and that's the typical appearance for after the Barrett's tissue has been ablated. So now the catheter is being advanced more into the distal esophagus to get the next segment of Barrett's esophagus. It's going back up, and the ablation is repeated. So this is an extremely safe procedure. The ablation part only takes about 10 minutes. We typically repeat it every 3 months until the Barrett's tissue is completely ablated. And most people will require about 4 treatments total. It's something to think about being screened for Barrett's esophagus. As I said, if you have a history of acid reflux, talk to your primary care doctor, talk to your gastroenterologist. The upper endoscopy can be done at the same time as a colonoscopy, and it's worth thinking about because I think it's something that's not often on people's radar, even if they're concerned about being screened for colon cancer. A lot of people are not aware that you can also be screened for esophageal cancer.